We described the life cycle of hepatitis C virus and looked at the mechanism of action of direct-acting antiviral agents. Now the next learning objective is given a patient with chronic hep C virus, recommend AASLD-IDSA guideline-concordant first-line therapy.
Now here's some reliable resources. American Association for the Study of Liver Diseases, or AASLD, in conjunction with, in collaboration with IDSA, have developed guidelines for, or I should say guidance for hepatitis C, which are freely available, and they are published online because they get updated frequently. In fact, more than once a year they update it, so they are published online. There's also the HEP drug interaction checker that you can actually, there's also a HEP iChart app that you can download for free, which allows you to check for drug interactions. So here's why, SVR12 is very important. And of course, SVR12 is just a lab value. It's a surrogate marker. So here's why it's important. So cure or SVR12, generally speaking, of course, if somebody achieves SVR12, that's gonna reduce transmission. So if somebody doesn't have the virus in their system, then they're unlikely to transmit it to other people. So that's very important. Another thing is improved clinical outcomes in the patient. And these benefits, clinical outcomes, include hepatic and extrahepatic. So of course, if you cure the hep C, there will be reduced rate of cirrhosis, reduced rate of decompensation in the liver disease, reduced risk of hepatocellular carcinoma, and reduced need for transplantation. And of course, there are also studies that show that SVR12 can actually reduce all-cause mortality, improve quality of life, reduce malignancy, diabetes, cardiovascular disease, and renal and neurocognitive disease. So, and of course, not only does SVR12 reduce all-cause mortality, the interesting thing is that it reduces liver-related mortality as well as non-liver-related mortality. So it's not all about the liver. It actually reduces non-liver related mortality. So that's why SVR12 is, although it's a surrogate marker, it's a surrogate marker for a very important clinical outcomes. So the guideline says the goal of treatment of hep C infected person is to reduce all-cause mortality and liver-related health adverse consequences, including end-stage liver disease and hepatocellular carcinoma, by the attachment of SVR. One of the extrahepatic clinical outcomes is actually diabetes, and in diabetic patients is renal disease. So in this study you can see patients who have diabetes and hep C, and if they're not treated, they are a lot more likely, significantly more likely to have incidence of end-stage renal disease, whereas when you treat them, they are significantly less likely to have end-stage renal disease. So SVR is extremely important for preventing end-stage renal disease in these patients if they have diabetes.
Now let's take a look at the therapy for hep C genotype 1 in treatment-naive patients. We will focus on treatment-naive because treatment-experienced patients are more complicated, and really the history of the treatment that they have received in the past basically plays a huge role. So we will focus on treatment naive. So TN is treatment naive. And let's start with genotype 1. By far, the majority of cases in the United States are genotype 1. And because there's so much variation in genotype 1, in fact, there are two major subtypes, genotype 1A and 1B, and they are a bit different. Now, when we consider patient population, we're going to basically break them into those with no cirrhosis, those with compensated cirrhosis, and then those patients with decompensated cirrhosis. Let's take a look at the first combination, Harvoni, which includes ledipasvir and sofosbuvir. For patients with no cirrhosis, when it comes to genotype 1A, 12 weeks of treatment is recommended first line. However, there's a subpopulation with no cirrhosis that can actually get this for 8 weeks, and that is as long as those patients with no cirrhosis do not have HIV co-infection, and as well as if the RNA levels at baseline are less than 6 million international units. If that's the case, then 8 weeks of treatment of Harvoni would be sufficient. Now, with those who have compensated cirrhosis, it has to be at least 12 weeks. Now, with those who have compensated cirrhosis, the treatment has to be 12 weeks, so 8 weeks is not sufficient. When it comes to decompensated cirrhosis, 12 weeks is enough as long as the patient can tolerate ribavirin. So Harvoni plus ribavirin for 12 weeks will be sufficient. For patients who cannot tolerate ribavirin, either because of contraindications or because patients with advanced cirrhosis often have anemia because of GI bleeding and because of other complications. So if the patient cannot tolerate ribavirin because ribavirin can cause hemolytic anemia, then Harvoni alone can be used for 24 weeks. Now you will see similar recommendation for genotype 1b when it comes to Harvoni. The next combination is Zapatevir, so it has Elbasvir and Grazoprevir. This combination for genotype 1a, 12 weeks is sufficient, and it doesn't matter whether the patient has cirrhosis or not. 12 weeks would be sufficient. Now, with this combination specifically, we actually need to test for NS5A resistant associated substitutes or RAS, and as long as the patient does not test positive for RAS, and that's what that is basically a mutation in NS5A, which will make treatment more difficult. As long as the patient does not have that mutation, 12 weeks is enough, and that would be first-line recommendation. Otherwise, if the patient has this mutation in the virus, then 16 weeks of treatment is recommended. And because we have other regimens that can be used for shorter duration of therapy, if you have to do 16 weeks of Zapatevir, then it's only recommended as an alternative. It's no longer first line. Now, this NS5A RAS only applies to genotype 1A. So if you're treating genotype 1B, you don't really have to worry about it. So 12 weeks of treatment would be sufficient. Now, when it comes to decompensated cirrhosis, this regimen, because it includes a protease inhibitors in general are metabolized in the liver. So if someone has advanced cirrhosis, it's actually contraindicated. So that's why this regimen cannot be used if patients have decompensated cirrhosis. The next combination is Epclusa. So Epclusa basically is a combination of Sofosbuvir and velpatasvir. For those with no cirrhosis and those with compensated cirrhosis, 12 weeks of treatment is enough. When it comes to decompensated cirrhosis, similar to Harvoni, addition of ribavirin is needed, and then you can do for 12 weeks. If the patient is ineligible to get ribavirin, then you do 24 weeks of Epclusa alone. And the same applies for genotype 1b. The next combination is Mavyret. Mavyret is a combination of Glecaprevir and pibrentasvir, and this combination, 8 weeks of therapy is sufficient for those with no cirrhosis as well as patients with compensated cirrhosis, as long as the patient does not have HIV co-infection. Now, this combination also has a protease inhibitor in it, so therefore in patients with decompensated cirrhosis is not recommended, or actually is contraindicated. Now, there are two more combinations listed here. One is Vosevi, which is basically Epclusa plus voxilaprevir. So it's a combination of 3 drugs. The reason it's not recommended for anybody is because it is such a potent combination that we actually reserve it for treatment experienced patients. So patients who fail other regimens are more likely to respond to this regimen. So it's not recommended for treatment naive because we're trying to reserve it for those who fail other regimens. And of course, voxilaprevir part is a protease inhibitor, so it's actually contraindicated for decompensated cirrhosis. Now, there is an older regimen, Pro-D or 3D, because it has 3 direct acting agents in it. The brand name is Vicera. And this one is no longer recommended first line because the regimen is more complicated, and we're gonna take a look. And because we have so many other options that are more simple for the patients, it's actually not recommended first line anymore. And this combination also has a protease inhibitor, so it's actually contraindicated in patients with decompensated cirrhosis. All right, let's take a look at Harvoni, which includes sofosbuvir NS5B inhibitor, which is basically a polymerase inhibitor, as well as ledipasvir, which is an NS5A inhibitor. Now you can see that between these two, sofosbuvir is about 80% eliminated renally, whereas ledipasvir is primarily eliminated through the feces. Now historically, because of these 80% renal clearance, sofosbuvir was contraindicated if GFR was less than 30. However, recently, because of recent data that we've had in patients with end-stage renal disease, you can see here there's a screenshot of the package insert for Harvoni, where the FDA actually says that it's okay to use Harvoni without dose adjustment in patients with end-stage renal disease, as well as those on dialysis. Now, one thing about sofosbuvir is that it has a high barrier to resistance, and what that means is that it is more difficult for Hep C virus to develop resistance against sofosbuvir, whereas ledipasvir, as a first-generation NS5A inhibitor, has a low barrier to resistance. The next combination, which is the Pro-D, actually includes 4 drugs. 3 of them are directed at the Hep C virus. So dasabuvir is a NS5B polymerase inhibitor, onbetasvir is a NS5A inhibitor, and paritaprevir is a protease inhibitor. Now you will notice that ritonavir, which is actually an HIV drug, is actually used in combination with this regimen, and it really does nothing. It does absolutely nothing to the Hep C virus. What it does is that it's a strong CYP inhibitor, and because protease inhibitors in general are substrates of the CYP enzymes, specifically CYP3A4, more than anything, by having ritonavir block the metabolism of paritaprevir, you can actually give a smaller dose of paritaprevir, which will help with the size of the pills. So what we do is that we use ritonavir as a pharmacokinetic booster. And what that means is that it actually boosts the concentrations of paritaprevir by inhibiting its metabolism. So really, although there are 4 drugs here, only 3 of them are direct acting agent. And you will see that ritonavir typically will be represented by a slash and an R when it's used as a booster. So it's basically boosting paritaprevir. Now you will see that pretty much all of these agents are, administered with food. So food is very important when this regimen is given to patients. And you will see that these are primarily eliminated through the feces. And all of these 3 have a low barrier to resistance. So that's why there are 3 of them, because none of the agents used here have a high barrier to resistance. So 3 of them are used in order to prevent emergence of resistance. Now here's what the original Vicera pack looked like. So it came with a pack. So each pack is for 1 day, and then it will, 7 packs would be a box. So there will be 1 box for a week. And then, they did a good job of showing that, half of it you need to take it in the morning, so AM, with the picture of the sun. And then 1 pill you need to take in the afternoon or in the evening, so they have the picture of the moon, and they all need to be taken with food. As you can see, there are 4 pills, so 3 of them are given in the morning, and then another one at night. So it's twice a day dosing. So not only so many pills, but also twice a day. So it made it very complicated. But to make things worse, you also need ribavirin, especially if the patient has genotype 1A. So in addition to this pack, you also need a bottle of ribavirin, which is actually dosed based on body weight. There are also pre-packed ribavirin formulations to make it a little easier. So this needs to be taken twice a day too. So this made it very complicated. Now, more recently, there was a Vicera XR. So basically, instead of 4 tablets, there are 3 tablets that you take at the same time. So instead of twice a day dosing, it's once a day dosing. So it's relatively easier to take. But regardless, you still need that ribavirin in a bottle, and ribavirin needs to be taken twice a day. So it's still pretty complicated. And this is, in fact, the reason that this regimen is no longer recommended first line. It is only an alternative. Now, let's take a look at Zepatier. So Zepatier also comes in a pack, but it's only a single pill that's taken once a day. One thing significant about Zepatier is that these are second generation protease inhibitor. So Grazoprevir is a second generation protease inhibitor, and Elbasvir is a second generation NS5A inhibitor. And what that means is that they have high barrier to resistance. So they're going to be very effective. It's going to be difficult for the virus to develop resistance, but also they're more tolerated. So second generation also means better tolerated. Now, these are basically eliminated through the feces, so no issues in renal dysfunction. Now, let's take a look at Epclusa. So Epclusa, again, includes Sofosbuvir, but what's different from Harvoni is that instead of a first generation NS5A, they actually replaced it with a second generation NS5A inhibitor, velpatasvir. So because of that, velpatasvir has a high barrier to resistance and also better tolerated. And of course, because this includes Sofosbuvir, which is 80% renally cleared, this used to be contraindicated in GFR less than 30. But you can see that the updated package insert says that the FDA says no dosage adjustment needed in end-stage renal disease, including those who require dialysis. Now, Vosevi is basically Epclusa plus another agent. So Voxilaprevir is a second generation protease inhibitor. So you have 3 high barrier agents here. So that's why this is a very potent combination, and it's reserved for treatment experienced patients who fail other agents. That's why it's not recommended first line. And of course, this also has Sofosbuvir, which is renally cleared. And again, the package insert says you don't need to dose adjust in end-stage renal disease, including dialysis. Harvoni, Epclusa, and Vosevi, they're all a single tablet once a day. So they're really nice for the patients. It helps with compliance. Now, Maviret, which is really popular because, for most patients, 8 weeks of treatment is sufficient. So, that makes it really convenient for the patient. It does include 2 second generation agents, one NS5A inhibitor and one protease inhibitor, so high barrier to resistance. They're not renally clear, so really, really nice combination. Now, it is 3 pills, but you take it once a day. So even though it's 3 pills, it comes in a pack, so it makes it easy for the patients to take all 3 at the same time, and they do need to be taken with food. Now, that was all for genotype 1. For genotype 3, it's important to consider a few things. First of all, genotype 3 is the second most common genotype globally. So genotype 1 is by far the most common. Genotype 3 is the second, but also genotype 3 is the most difficult to treat. And specifically genotype 3, it can actually progress to fibrosis a lot faster. So patients will be at high risk of hepatocellular carcinoma and complications of hepatitis C. And we don't have as many agents again. So pretty much most of the agents that we have had over the past few years didn't have activity against genotype 3. Except recently with the newer agents, they are typically pangenotypic. So now we're starting to have good regimens that have good activity against genotype 3. So when it comes to genotype 3, you will see that Harvoni is not indicated because it doesn't have activity. Specifically, ledipasvir doesn't have activity against genotype 2 or 3. In this table, I'm showing you genotype 2 and 3. The same thing is true about Pro-D and Zepatier. So these are not used for genotype 2 or 3. And so the two regimens that we use for treatment naive patients is Epclusa and Maviret. So Epclusa for genotype 2, if the patient has no cirrhosis or compensated cirrhosis, 12 weeks was enough. And then for decompensated, you need ribavirin, so similar to genotype 1. When it comes to genotype 3, for patients who have compensated cirrhosis, for Epclusa, we also need to check NS5A resistant associated substitution. So if there is a mutation detected, then the patient actually can use Maviret instead. So Epclusa would be an alternative if the patient has that mutation detected. Otherwise, Epclusa is recommended first line. Now, when it comes to Maviret, 8 weeks is recommended for no cirrhosis, and then for compensated cirrhosis, 8 weeks is recommended as long as the patient does not have HIV. If the patient happens to have HIV for compensated cirrhosis, then 12 weeks is recommended. The same is true for genotype 3. And of course, Vosevi, we save, for treatment experienced patient, it is active against genotype 2 and 3. As you can see with genotype 3 for compensated cirrhosis, because we only have 2 options and one option potentially will be an alternative because of RAS, Vosevi is recommended as an alternative for treatment-naive patients. But other than this, Vosevi is not recommended for treatment-naive patients.